Today's speaker is Renee Sisk, and she is with the North Dakota Department of Health.
Thank you. As she said, my name is Renee Sisk. I'm the program administrator at the Department of Health in the Division of Medical Marijuana. And I've been there since June of, 2 years ago. So been there almost 2 years. And before that, I worked in another place in the Department of Health. And I'm actually a nurse by background. So just shows how broad the nursing career field is, in that now I'm working in the Division of Medical Marijuana. I recognize a lot of your faces because I lived in Minot before and worked for First District as a school nurse. So it's fun to be back. I knew exactly where I was going, so that's always fun. This is a small group, and I like to start out presentations like this just asking what you want to know. It seems like sometimes these interactive presentations, asking you what you've heard, what you want clarification on, what you are hearing from people in the public, helps kind of guide the presentation. So just get it out there. What are some things that you want to learn today?
So, what's the difference between the medical marijuana versus the street marijuana?
Okay, the difference between medical marijuana and street marijuana. Well, one of the main differences that I think is that ours is very much regulated, and we have administrative rules and law for testing, compliance testing. So, for instance, no product is allowed any pesticide whatsoever. They also test for mycotoxins, different things like that. Another thing is they test for concentration levels. So what the product is, or what it says it is actually what it is. I've heard some stories about some other products in stores that when they've actually gone to do some testing, there was a study done just a couple months ago, and it wasn't even close to what it said it was. So, that's a main difference, especially in our population. It's a medical program, so we have immunocompromised patients, and we definitely don't want them using a product that has some of these contaminants or anything like that in it. Yeah.
Have there been any medical studies that have actually indicated, good medical study for the risks and benefits of marijuana?
Yeah, so a question about the studies being done. Thank you. They are slowly coming about, especially in the United States. There are a lot of studies in other countries. Israel is one that has a lot of studies that has been done. But because of the federal illegal status here, it does cause some problems as far as the studies being done here. It's a funding thing. Most places you can't get grant money to fund an illegal substance and the research of it. It's not FDA approved, so it doesn't have that whole, study process. Like, that goes through years and years and years of testing and studying to get FDA approval. So it's very different, and so it's coming along, but it's not quite there yet. There are some universities now that are implementing programs and sort of starting the process of that, but it's something that's needed, and that information is just craved, especially by the medical community, because we'll talk about the healthcare provider role in this program, the doctors, the nurse, the APRNs, and the PAs, but really they want a lot of that information, and it's just not quite there yet. So it's a work in progress as far as studies. Yeah.
So you might answer this question during your presentation, but are medical providers willing to write that prescription?
Yeah, so.
I don't think from experience, I think it's just people's perception that the doctors aren't going to.
Yeah. And you actually bring up two good points. First of all, you did what is typical in saying a prescription, which is, don't feel bad about that, because that's what the whole medical community is growing up with, and that's what they're used to. But it's not a prescription. You can't prescribe a Schedule I substance. So what it is a written certification. And each time I do a presentation, I'll say, it's not a prescription, because that's what they're worried about. And then the first question out of their mouths after I say that is, so about this prescription. So it's really hard to change that mentality, which I understand. I mean, I'm in the medical field too. But as far as their willingness to do it, there's a couple things to take into consideration. First of all, healthcare providers, which originally in the law were defined as physicians licensed through the North Dakota Board of Medicine and APRNs licensed through the North Dakota Board of Nursing. And they had to have a license in good standing at the time that they signed a written certification. Now, with the latest legislative changes, which we'll talk about to some of the changes that just recently happened, they added PAs to that, so they just have to be licensed in North Dakota with a license in good standing also. They're protected, all healthcare providers that are defined in our law are protected whether or not they choose to participate in the program by completing a written certification. So they're protected if they choose to participate, and they're protected if they don't want to, if they refuse to, which is sometimes hard for patients. Patients want us to have that authority to go in and say, oh no, you have to do this, and we don't. The state and the division does not have that authority. It's at the discretion of the healthcare provider. So it depends on where you are. We have seen in other states, it's a slow process getting healthcare providers to participate, and even getting patient applications at first. You know, in other states that have implemented programs, it starts really slow and then it gradually grows and gradually grows, and that's kind of what we've seen here. You know, there are certain facilities that have said that they're not going to allow their healthcare providers to do this, and then there's other facilities that have said they're leaving it up to each individual provider to determine what is best for them and their patient. So it's really spread out throughout the state. But I will say our number one phone calls that we get in our division are related to patients having a hard time finding a healthcare provider. And while we're talking about healthcare providers, this is one of my slides later on, but we might as well talk about it now. We have what's called the Bonafide provider-patient relationship defined in law, and this is where it can get a little tricky, because basically this is saying, I feel like the intent of the law was that it makes sure that patients are still seeking care for the condition that qualifies them for the program. So let's say they have anxiety disorder, which was a recently added condition. You know, once their healthcare provider signs their written certification and says, yeah, let's try this, let's see how it works for you, the intent is for them to keep going to that healthcare provider to monitor the process and see, is it working? Is it having a detrimental effect? You know, do we need to change something? And so this Bonafide relationship really was set in place to protect patients, to make sure that they're still getting help for their, or you know, getting care for their medical needs. It also prevents certain maybe outside entities from coming in and just setting up what we call their pot docs. They might work out of a hotel and say, for $200 I'll sign your written certification, here you go, you never have to see me again. It kind of prevents that, because it mandates that there's some type of the intention to follow up care. It has to be an established relationship. They have to have created a medical record, do an in-person medical evaluation, different things like that. So when patients call and they have that worry, they've talked to their healthcare provider or multiple providers, and they're not willing to do the written certification, they are in a tough spot. And we tell patients, you really have a decision to make. You can always establish care with somebody else. That's your prerogative as a patient. You never have to stay with your same healthcare provider. But when you go to establish care, you establish care for the condition that, you know, that like the anxiety disorder or the chronic pain. You don't establish care to have them sign a written certification, because that is, it can't be for the sole purpose of completing a written certification. So it's hard, because patients, if they call a facility and just call reception, a lot of places don't even let them get past that, and you know, they'll say, well, none of our providers are doing that. Well, I tell patients, call and just say you want to establish care for this condition. And once you've established that relationship with your provider, that's when you have the discussion of would they potentially participate? But that doesn't guarantee that that provider will do it either. So this is the problem that patients are having. They try and establish care, and then that provider is maybe unwilling to write the written certification too, so then they are stuck again. So it's definitely a concern, and patients get frustrated. Another thing is we cannot, by law, release any healthcare provider names that do participate in the program. We get that call all the time, like, well, can you tell me who to go to or who? We can't. We're bound by state law. There's a confidentiality clause in there that anything on the patient application, including the healthcare provider name, is confidential. So we don't ever release that information, and I would say 99.9% of the healthcare providers don't want their information released. They don't want patients just calling for that purpose. So are there any other questions on the healthcare provider aspect of things? Some of the conditions we added, I'll talk about those since we were on there. I think we had something like 14 conditions before, and recently in legislation, 12 more were added. The 12 that were added were anorexia, anxiety disorder, autism spectrum disorder, which was a big one especially for the minor population, brain injury, bulimia, Ehlers-Danlos syndrome, endometriosis, interstitial cystitis, migraine, neuropathy, rheumatoid arthritis, and Tourette syndrome. So all of those conditions were added this legislative session. And we'll talk about some of the really great legislative changes I feel that really put the patients first this session, and after we do kind of a review of where the program is at. So I will say with our conditions, the one that was approved from the get-go, from the first law that was passed, was chronic pain, and that's kind of the catch-all. Even, for instance, even rheumatoid arthritis that was recently added, technically, in my opinion, it probably could have fallen under the chronic debilitating pain because it's a debilitating disease that hasn't responded to different treatments and things like that. So technically I feel like it could have fallen under the chronic pain, and some providers have done that. That's kind of the catch-all. Not all states have chronic pain in their list. So I think for patients that are struggling with that here in North Dakota, it's been good for them that they are able to at least see how this works for them. And our job at the division as the regulatory agency, I really have to balance that because I, as an RN, have the patient advocacy background, and so of course I want to help the patients. At the same time, the regulatory role is to make sure we are functioning within the law. And so even though I might want to say something, I am bound by our state law to not give certain information or anything like that. So it's an interesting role, but I'm glad I get to do it because I do get to work with the patients a lot and take calls from them. So we'll just back up a little bit and go to basically an overview of the program. We've made some enormous strides since I first started almost 2 years ago. If you look in the public, they will say it's taken way too long. However, our program was in line with sort of the average of the nation as far as getting implemented and start up. Generally, it was 18 to 24 months from start to finish, and a lot of people like to use the date that the medical marijuana was voted in, but technically the legislature at that time delayed it to make some fixes, and so it didn't get signed into law until April of 2017. So we were well within the 18 to 24 months that most states see. Some are longer, some are shorter. It seems though that the ones that rushed to get their programs implemented are now having to go back and fix a lot of things, and they're kind of a mess. So even though it probably didn't go as fast as the public would have wanted, we wanted to make sure that we implemented a program that was well regulated, and the most important factor was safe for the patients, making sure that the products they got and everything was within the law and safe for them. So by law, we have 2 manufacturing facilities and 8 dispensaries. All of these now have been selected. which means the review panel that reviewed applications have chosen the highest scoring one and selected them. Out of the manufacturing facilities, both of them are operational and have what's called the registration certificate from the Department of Health, which means they're allowed to have plants and grow and process. The manufacturing facilities are the growers and the processors all in one. So they have from the plant, the beginning stages of the plant to the final products of whether it's a solution or dried leaves and flour or an ointment or something like that. They do all of that. One is located in Bismarck and one is located in Fargo. The one in Bismarck is the one that has been processing products up to this point. The other one is still in the process of growing plants. So getting closer and closer every day to having them both being able to supply the dispensaries. Out of the dispensaries, the first one that opened was the one in Fargo. It's called The Botanist, and they have been open since March 1st. And the next ones that will open looks like it's going to be the one in Grand Forks, which is Strive, and then the one in Williston, which is Harvest. The other ones, Bismarck, Jamestown, Dickinson, Minot, and what's the other one I'm missing? I can't think of the other one I'm missing, but those are still in process of doing their renovations, getting their facility up and running. It's a huge startup cost for these places. The state does not give any money, which is sometimes in the public they think that we pay for these places, but we don't. These places have to have their own money to start up their business, and actually they pay a registration fee every 2 years to the department. So for dispensaries it's $90,000, and for manufacturing facilities it's $110,000. So that's when they get before they get their registration certificate, they pay that fee to us, and that's on top of their building and all their equipment that they need. So it is a lot of money for these places. And one thing that I think the public needs to know also is that because we require compliance testing to make sure these products are safe, that's an additional cost to manufacturing facilities. And ultimately, that does raise the cost of products. However, we need to make sure that the products are safe and are what they say they are. So it's kind of a catch-22. You have a good, regulatory, the lab does the compliance testing, and then we know the products are safe, but it does raise the cost, of course, because it costs money to run those tests. So the dispensary in Grand Forks, we think, will be open still the end of May, either next week or the week after that. We're still on track for that, and Williston shouldn't be too far behind. A patient can go to any dispensary once they have a card. They are not bound to go to the one in their area or anything like that. They can go, like if they visited Grand Forks, they could drive and go to Fargo. However, our traceability system, it's interconnected. So, they only have so many, they have limits that they can purchase in a 30-day period. So if they go to Grand Forks, it automatically comes off of their limit and they could travel to Fargo, and that will show, okay, you only have this much left. Yes?
So you could be 18 walking in?
You have, actually, the definition of a minor is over 19. So 19 and older is considered like an adult patient, and under 19 is a minor. And so there can be minor patients in the program, but they're not allowed to go into the restricted access areas like where these products are in the dispensary. They have to have a designated caregiver. So whether that's a parent or a friend or somebody that they just found to be their designated caregiver, that's who would purchase product on their behalf.
Okay, so I'm just picturing this. If I'm walking in, is it like you walk into a reception area and then you go into the back?
Yeah, most places and most of their plans have like what's called the lobby, where For instance, the one in Fargo, you even have to get buzzed in from the outside to the into the lobby. But then once you're in the lobby, like, you don't necessarily have to have a card. Some people go in for information, just to ask a question. But back where all the, sales are and the products and stuff like that, that is what's called restricted access. So you have to have a card to go back there. Yeah. And while we're talking about designated caregivers, they are unique in law in that they have to be over 21 and they have to have a criminal history record check completed and they have to pass that. So the criminal history record check is for designated caregivers and then any what are called agents of the compassion centers, the dispensaries, and basically they're employees of the manufacturing facilities and dispensaries. They also have to be 21 and pass a criminal history record check. And to pass that, you can't have a drug-related misdemeanor in the previous 5 years or a felony offense ever in your lifetime. So we run those through North Dakota BCI, and then they go on to the FBI, so it's national and state that we check those, which is a good thing, I think, for caregivers. Caregivers can have up to 5 patients, so I think it's good just to make sure that's a lot of product they could have in their possession at one time, so just to make sure that there's nothing that would, stop them from abusing it. Hopefully that helps eliminate some of that. So any other questions on sort of the, yeah.
So the ones that dispense in this state, do they have to use the manufacturing facilities just from this state?
They do, yep. So all of them have to use the 2 manufacturing facilities here, registered under the program.
And I'm not familiar with like around state lines as far as monitoring. If they go to different ones within the state, it will show their limits, but do you have any agreements with other states as far as monitoring?
We don't have reciprocity, and so basically we don't accept other states' cards, and if other states accept our ID cards, is on them. So patients would have to check there. However, interstate, travel is, because it's federally illegal, that would put somebody at risk. Like if they were to go into Minnesota, if they were stopped and they had product from North Dakota, that would put them at risk at being in violation of the law. So it is one of those things too where patients, if they are part of the program and they travel or like go down to Arizona for the winter or something, they ask that, but really they would almost have to have 2 separate cards, one in North Dakota for when they're here and one in Arizona when they're there. However, like I said, some states are recognizing other states' cards. We just don't, because our state laws are all so different. It would be really hard for us to monitor that. There was proposed legislation this session that talked about reciprocity, but I think after it was kind of hashed out a little bit, they took that off. So it is really hard when states are so diverse in what their laws are. So like for instance, Minnesota doesn't have dried leaves and flowers. They don't have the smokable version. So that would be tempting probably for Minnesota residents to come to North Dakota, and because they could purchase that here, but we don't recognize their cards. So.
Are the 2 manufacturing facilities the same company?
Nope, they're separate. Technically, nobody that holds a registration certificate for any of the dispensaries or manufacturing facilities can be the same legal entity, but there are some companies that have set up separate legal entities. So they're kind of the same overall company, but in North Dakota, when they registered with the Secretary of State, they are separate legal entities. So if they have the same, let's say, regional manager or something, if they have like 4 different facilities, they would have to apply 4 different times and pay their, to get a card, pay their registration fee 4 different times because they're separate legal entities. So, yeah. Any other questions on the facilities? Yeah.
So
Okay.
it's kind of a personal question. So why did you choose to get into this versus other types of?
I had been at the Department of Health, and I looked forward to the opportunity to work with a brand new program. I thought it sounded interesting. The director that was there, so they had hired a director like during the previous legislative session to kind of go to the legislative hearings and all that different stuff. And I really respected him, and I thought he would be great to work with too. And so it was just intriguing to me, and especially because of the medical aspect of it. I just thought there was a lot to learn there. So that's kind of why and it was an easy move, just basically across the hall. So it wasn't like I was starting all over or anything. So
do each dispensary get to set their own cost of what they charge to people?
yes, they do. Regarding the cost, that is another topic that we hear a lot about. It's really hard to compare North Dakota prices to, we get this a lot, Colorado, because they also have rec and they have an abundance of product. Like they have too much product. And so of course it's going to be lower prices. And each state has different testing requirements and things like that. So prices vary. I think that our prices at the one dispensary that's open now are comparable across the nation if you look at other places with just medical and just starting out. But ultimately, yes, we don't have authority to mandate any specific prices. However, we can monitor. And as part of the application process for these facilities, they had to submit a section on how they're going to make products affordable for patients. So we can hold them to what's in their application. And ultimately, I think the more it grows, the more facilities we get open, basic economics, a little competition is good. So hopefully that will help kind of drive the prices down a little bit. I know that a lot of them offer certain discounts for, like the ones that don't make much money, or veterans, for instance. They have certain programs for that where they get a percentage off. So low income or veterans. Yeah.
Are there guidelines or protocols for the people who are writing, I forgot what you called it, but
The written
the
certifications.
certification? Like, do they have guidelines? Like, I thought I saw somewhere in the beginning stages of the legislation that smoking was not entirely recommended. They prefer like the oils or first.
Yeah. In the first law that was signed, smoking, or the dried leaves and flowers as we call it, took a special authorization from the healthcare provider. So it was really at the discretion of that healthcare provider. There might be certain situations where that is the best form for them. Sometimes I think like if they have trouble swallowing, I think of certain cancers or something like that. But that was taken away this legislative session. So basically now, everybody that's not a minor has access to the smokable version. That doesn't mean everybody wants that version. A lot of them are more interested in what we used to call the tinctures. Now they're called solutions, or ointments or capsules, or we have transdermal patches that are approved. So a lot of them are interested in those products. They don't want to smoke, but they are allowed now everybody's allowed access to the dried leaves and flowers other than minor patients. One other legislative change was that there is what's called an enhanced amount of dried leaves and flowers for cancer patients. So we found, and I think the legislator, I think this really came from whether they talked to people in the public during session. Somehow it came about where they considered this enhanced amount for patients that have the diagnosis of cancer, because they can go through the dried leaves and flowers much faster, just for pain control and different things like that. So the healthcare provider can now authorize an enhanced amount, which now everybody can purchase up to 2.5 ounces in a 30-day period. But for cancer patients, they can, if they're approved for the enhanced amount, it's 6 ounces in a 30-day period. So, and then possession limits are a little bit more. So possession limits, because, just like with a prescription medication, you don't wait till the last day until you go in and get your refill. So basically, the law allows for them to have a little bit over that amount in their possession so that they don't run completely out before they go back to a dispensary. So possession limits for dried leaves and flower are 3 ounces for the standard amount, or 7.5 ounces for the enhanced amount, which can be a lot. And then you think if there's a designated caregiver that has 5 patients, they could potentially have a lot of product on them. So, but that's what the changes for that were. They also upped the, so we have basically 2 different, we have the dried leaves and flowers on one side for limits, and then we have what's called the other products on another side. And previously, they were allowed 2,000 milligrams of THC, the psychoactive ingredient, in a 30-day period. 2,000 milligrams total of THC, no matter what the product was, whether they bought a capsule, a patch, solution, whatever. And now that's gone up to 4,000 milligrams in a 30-day period. So that did increase also. But there's no possession limit on those other products, which is kind of odd to me. But
How do the smoke-free laws affect that?
same as tobacco, cigarettes. That's kind of what we say. You know, people do call and they ask, like, well, what about in, you know, the privacy of my backyard? And it's their private property. However, you know, we say you might want to have a conversation with your neighbors, because if they, you know, I don't know, it's hard. It's hard for them. They don't want to do that like in the house or in an enclosed area if they can be, you know, like in their backyard or something. But that's hard. But we do say the same, you know, regulations as with the tobacco laws. So, yeah.
So, you know, we have the secondhand smoke,
Mm-hmm.
you know, the hazards from the cigarette. Is there anything to worry about with pot?
Well, I'm sure there is, but they should not be smoking around like minors or anything like that. But I mean, if you've ever been I've been to Arizona before, or maybe Nevada. I think it was Nevada. I was at a concert there, and it can be strong. You know, I can see where it would irritate people. Let me get that right. I wasn't the one doing it. It was somebody off in the concert. But yeah, you know, I could see or asthmatic people where it could irritate that. And like I said, it's not for everybody, and I don't think that that's what they intended it to be. There are patients that call and say that they've been in other states and tried this for a lot of times we hear like PTSD, where they don't like the effects of like a solution or, you know, something like that, because they kind of get full body effects from that, and they just like more here, and they say for them smoking is what works for them. I don't know. I'm not an expert in that, but you know, I just listen to what patients tell me and what their experience has been previously. And I'm excited to hear from patients, and we are working on getting some sort of survey or data to hear, has this been helping your condition? What's been good? What's been bad? What, you know, just to find out the information on that. Interesting to see for those chronic pain patients that are currently on opioids and other strong medications. Has it decreased their use of that? Have they, I don't know. Because a lot of patients call and say they really just want to get off of the opioids, and so they want to try this to wean off of those. So
let's say, for an example, you have like back issues.
Mm-hmm.
You smoke marijuana. Is that like a Band-Aid to this? I mean, are they using that instead of like going to a healthcare provider?
Yeah, well, and I think that's sort of why they need the healthcare provider written certification, and why that Bonafide relationship is spelled out in law, like with the follow-up care, monitoring it, because that's what they don't want, is for them to just, you know, do this and never see the healthcare provider again until a year later when they have to reapply. And, you know, so I don't know. That's some of the data that we'll have to see, you know. It'll be interesting to see. And we have no control over what meds they take on top of this. You know, that's not on us. That's not our role as the state agency to, you know, reconcile their med list or anything like that. That's definitely something that their healthcare provider knows and handles. So, and I think that's one of the concerns of healthcare providers, because they don't have those studies and whatnot to see. I mean, there are becoming more and more, but that's, I think, one of the drawbacks in the medical community, is that these healthcare providers really, they want to know how it works, they want to know the effects, they want to know, they just don't have a lot of that information yet. And they're not the ones that are in charge of dosing or choosing which products work for certain conditions. That's up to the dispensary staff, and they're the ones that have that information. So when a patient goes, to their healthcare provider, and the healthcare provider agrees to sign the written certification, then the patient visits the dispensary, and that's where they get the information, like, oh, you have fibromyalgia, normally this works best for this, and start at this dose and see how it goes, start low, go slow. That's a lot of times what they say. So yeah.
So are there any defining requirements written into the law, or is it all voluntary? You say, you follow up with people with the cards or conditions.
Mm-hmm.
Is that mandated in the law that they complete those, reports?
We have the authority to request medical records as part of the patient application. We do that, and a lot of times my job is, when a written certification comes in and the patient application, my job is to validate and verify information in that written certification. So it might be me calling the healthcare provider, calling the doctor, the nurse, just saying, okay, I just want to verify some information. Is this what's consistent in their medical record? I can request records to verify if I want. I can even ask if I can stop by and visit with them, or things like that. We've done in-person visits before to healthcare facilities. So I don't say we do that for every single one, but definitely healthcare providers that are just starting, like their first written certification that comes in, I always call at least to make sure that it truly was them that submitted this. We do have an all online process, but people are sneaky. There's going to be people that try and do things on their own without having the proper people doing it. But we hope that we have a system set up that avoids that and decreases the risk. And then by me doing validation work, verification work, that helps too. But we ask about follow-up visits, like, do they have a follow-up visit scheduled? Or, sometimes even right in the notes, they'll say they're supposed to follow up with me in 3 months or whatever. So we do our best to verify that. A healthcare provider can also rescind a written certification if first they don't think that Bonafide relationship exists anymore. And in fact, we have had a healthcare provider rescind one because the patient came back for a follow-up and was apparently not well behaved at all, and so he cut ties, and he said, we no longer have this Bonafide relationship, so I am rescinding my written certification, and that's their right to do. So any other questions on that? Yeah.
So as far as the ones that are doing the dispensing and choosing these doses and evaluating the patient when they come in, what are the requirements for that, and what education has to be provided, say at the first visit and for each follow-up?
Yeah, it's that's a great question, because I've always said, well, the dispensary agents or staff are the experts at this. And somebody said one time, well, what makes them an expert? And I said, that's a really good question. But a lot of it is related to what was in their application to begin with and what they have for resources. For instance, some of them have entire educational teams consisting of medical doctors and pharmacists and different things as a resource. Not that they're there every day at the dispensary, but that's who they can reach out to ask questions. They have different training requirements within their facility, but that's something that I've been asking more and more about too, as far as just the different education, and if they can provide even education to the public or the healthcare community and stuff, because like I said, they're the ones that know the products and know the dosing and know what works for what. And so that's something I'm still learning too, but a lot of it was based in their application to begin with. And it did include like, a medical director or somebody like that was a doctor of some sort. So, and a lot of them are from other states. Like those specific people are in other states that have already had programs for a while, so they're more familiar, with the products and the effects of them and different things. So.
Is there anything written into the law for, say for example, if someone uses medical marijuana and then drives?
There is. Yep. There's impairment language in there, and really it falls under. I think we reference, what is already in state law for that, because it's still you can't drive impaired or anything, operate a boat impaired or things like that. So that is basically reference to those other laws. And then on packaging, I think it's on packaging. There has to be a little blurb about that too on the final packaging. So. Speaking of packaging, the manufacturing facility does all of the packaging. Once it gets to the dispensary cannot open a package. So everything is in its final form once it gets to the dispensary, and then that's what goes to the patient.
How long does it stay in your system?
Well, I think it really depends on the type and the how long they've been using these products. So I don't know for sure.
Say, well, I mean, they can't drive if they're impaired, but it's like,
I think there's a difference between, because from what I've heard, THC and the remnants of that, like what they would test for, can be stored in fat cells in the body for a long time. Like you hear like 30 days or something. However, like the impairment part of that probably is a little different. And actually I've heard from, I heard a speaker from Colorado law enforcement who was telling us one time that their law enforcement officers are also phlebotomists. They were all trained in phlebotomy because whatever indicates the impairment leaves the system quickly. That's what they were saying. So I think there's a difference between like long-term, you can still see this, but what is impairment and the test that does that. So, and it is hard for law enforcement officers. It's hard, drug recognition and impairment, from what I'm told, my brother is a cop, he says that's a lot of training to do that. So it's not just cut and dry, for sure. So, some other major legislative changes, we did work with the legislators, and I think this is really good for these patients, but veteran patients, if they were seeking care at the VA doctors could not complete a written certification because they are a federal entity, and so they were really stuck. They didn't have any healthcare providers that even had remotely the possibility of participating. So what was proposed and eventually passed was that veterans, they can submit to us their medical records from the VA, and also basically a form that shows that they're a veteran, like their DD-214 or some type of discharge paper that shows their veteran status. And then we have additional questions. I call them, I talk to them, ask them, what is the condition or what are the conditions that qualify you for the program? They tell me, I ask them about different things, and then they get their records to me, and we at the division review those records and see, is there sufficient documentation here to ensure that that diagnosis is correct. And so in lieu of a healthcare provider completing a written certification, we can request records and go that way. So that is good for those patients, because they really, the number of PTSD that we see in them and anxiety is astronomical. The number of suicides we see in that group is crazy high, and so I think that this is hopefully a good option for them. But trying to think what other, with manufacturing facilities, they were previously limited to 1,000 plants. They had a 1,000 plant limit in their facility and could never have more than that. And this is all tracked in what's called our traceability system. So as soon as a plant develops a leaf, they tag it, and we can track it from when it was tagged till its final product, can see who that product was sold to, so it's like a seed to sale tracking system. But now this session, they increased where they didn't have that 1,000 plant limit anymore. They can basically grow and process plants and products to meet patient demand. So it depends. They do have to pay an additional fee, like every so many plants that they want to grow. I think, is it every 500 more or something? They have to pay like $10,000. So it does come with a fee. But I think that is also good. It allows these facilities that have already invested so much money and time and effort to be able to expand if the patient need allows for it. So we are at roughly, how many cards? Maybe 380 patient cards and designated caregiver cards. So it's slowly getting up there. We have more, agent cards, employees of facilities, and that will keep getting up there too. But that just allows them to work in their facility. They can't go anywhere else, and employees can't purchase products or anything like that with an agent card. That just basically allows them to be in their facility and work. So trying to think what else. Any other questions in general? I know we do get a lot of people that are not super excited about the online application because a lot of patients are older, didn't grow up with the technology and stuff like that. So we do try and walk them through how to do things, and some of them even just go to a public library and use the computer there or ask for help. And what we really tell them is, do you have a friend or a family member or close neighbor that could potentially help you with this? Because our staff we have 4 full-time employees. We just hired 1 more, but we're a really small division, so we just can't go out and help them as much as we'd like to. But that it's an online process, and if anybody ever comes in with any questions, we're more than happy to visit with them, visit with you guys. You can call or email anytime. I did put my contact information here. Trying to think if there were any other major changes. I don't think so. We had some housekeeping things in one of the bills that passed this session. One major thing is, before the application fees, we required check or money order or cashier's check. That's how it was written. And now we are allowed to do online payments for applications. It's still in process. We haven't gotten all that software up and running yet, but that will be coming, so that will be nice for patients that don't want to mail in a check. Trying to think what else. It's really been a process, and sometimes it's hard to see the scrutiny, I guess, from the public. And I sometimes just read social media posts, and I shouldn't, but I think a lot of times it's really hard not to respond or reply. But I think a lot of times when people actually take the time to call our office and they know what we've done and that we are doing everything possible to make this program successful while staying within the law, they have a much better feeling about it. And I always ensure them that we're all here to see this program be successful. It was voted in by the people. Whatever your opinion of it is, it doesn't matter because it's law, so we have to implement it. And so we do our best to do that. And I will say, I think every single one of us that started in our division, whether you were a skeptic at first or, just kind of iffy, I think the more you research and the more you talk to these patients and the more you know that you have certain safety things in place, maybe the more open-minded you become about it. But as long as, like I said, it's within the law. And I don't know federally, there's been a lot of talk about, changes, but It really causes a lot of problems with the federal illegal status versus them saying, okay, it's illegal, but states, you go ahead and make your own laws about it. It causes a lot of problems. It causes banking issues. You know, for the most part, it's a cash business because no banks will deal with it. So banking issues and just law enforcement is placed into a difficult position. And so I hope eventually, one way or the other, it changes at the federal level. Because I was at a conference one time and there was this really smart guy. He had, I don't know, he had multiple degrees. He was a doctor, he was a lawyer, he was just all these different things. And he said there is no other thing where it's, you know, that it's federally illegal, but it's legal in states. Usually it's the opposite. Like states can have more restrictive laws, but they can't be less restrictive than the federal law. But this is just the opposite. So with that, I think we can wrap it up. Were there any other questions? Okay. Thank you.
And we just want to say thank you as well. We have a certificate.
Oh, thank you.
And also, please make sure to complete your survey from today, and we also have additional lunch and learns the rest of this week. So thank you again very much for coming, and we really appreciate your time today.
Yes, you're very welcome.